Good afternoon, everyone, and thank you for joining us for our quarterly virtual council meeting. I'm Brandy Benson, Executive Director of Quality Insights Renal Network 5. Before we get started, I want to go over just a few housekeeping items. First off, all lines have been muted. You can unmute yourself if you want to ask a question, or you can put your questions in the chat and we'll cover as many of those as we can at the end as time allows. And of course, this session is being recorded and will be posted on our website along with a copy of the slides. For those of you who are new to dialysis or new to Network 5, we are Quality Insights Renal Network 5, and we serve as the contractor to CMS, and we cover Virginia, West Virginia, Maryland, and DC. As the ESRD network for Region 5, we are responsible for helping dialysis providers and transplant centers provide quality care to patients with ESRD. There are 18 networks like ours across the country, and depending on how long you've been in dialysis and in Network 5, you might know us as Mid-Atlantic Renal Coalition or MARC, but we're also known as the Network or Network 5. We answer to all of those things. In this area, there are over 27,000 patients on dialysis. 17% are home dialysis patients, and over 20,000 transplant recipients in our region. We're down to 439 dialysis facilities in the network and 15 transplant centers. I always share this slide as a reminder of the standard and the conditions for coverage that specifies CMS's expectation for dialysis facilities to cooperate with the ESRD network designated for its geographic area in fulfilling the terms of the network's current statement of work. Each facility must participate in ESRD network activities like this one and pursue network goals, which I'm going to cover in just a few minutes. During this presentation, we're going to share information to help you be successful in meeting this standard. Our current statement of work is divided into 3 areas: patient services, quality improvement, and data management. We work in 12-month performance periods called option periods. Each performance period runs May 1st to April 30th. Our current contract performance period, known as option period 4, just started on May 1st and will continue until April 30th of 2026. With the start of this new performance period comes a few modifications. The ESRD NCC contract was terminated unexpectedly. You may know the ESRD NCC as the supplier of the data to the network. The termination of this contract means that the network is without data. While the network has access to EQRS, the necessary reports needed to support our quality improvement efforts are not available. However, reports are being developed, and as soon as we have access to data, your ESRD facility report will be updated. Additional changes to our contract include the removal of the site visits and patient engagement measures. At this time, I will share an update on the network's progress towards meeting our goals from the most recent performance period, which ended April 30th. Due to the early termination of the ESRD NCC contract, the most recent data available to us is from March 31st. Consequently, we are unable to determine with certainty whether the network would have fully met its goals. So I'll review these bar charts like I have in the past. You should be familiar with the royal blue bar, which represents our baseline. The navy blue bar in the middle is our performance, and the gold bar is the goal that CMS set for Network 5. So first, we'll take a look at incidents to home. So this was new patients within their first 90 days of starting dialysis, selecting and moving to a home modality. So we had over 1,100 patients start a home modality. The goal was over 1,600, so we were on our way, but more than likely would have fallen short on meeting that goal. Same thing with transitions to home. So that's looking at patients who have been on dialysis for more than 90 days and moving to a home modality. We had a little more than 850 patients move, and we needed over 1,200. So again, making good progress, but probably would have fallen short on meeting that goal. However, I do want to recognize a few facilities who have done outstanding things with meeting home measures. FKC Kanawha should be commended for their cooperation and follow through on their home PDSA cycle and 10 direct-to-home transitions. BMA Crystal Spring had 12 transitions to home, and FMC Surratt's JV had 10 direct to home and 7 transitions to home. Great job. Thank you so much for your contributions and all of the other facilities prioritizing moving patients to a home modality. For this new performance period, the one that just started May 1st, home will remain a primary focus for the network and CMS, with a goal of achieving a 30% increase in the number of incident patients moving to a home modality. Again, that's patients within the first 90 days, and then an 18% increase in the number of patients who have been on dialysis for more than 90 days moving to a home modality. I really want to stress the importance that these goals apply to all facilities, regardless if you have a home program or not. This is really about educating patients and helping them move to a home modality, regardless if your facility offers home or not. With transplant, we had 2 measures the previous performance period. Waitlisting, Network 5 has always done a great job of adding patients to the wait list. So over 1,700 patients were added to the wait list in this 11-month period. We exceeded that goal. And then over 1,200 patients were transplanted, but the goal was almost 1,500. So well on our way, and very well could have met this goal if we had the final data set. So thank you all for your work in this area. Elizabeth has done an excellent job of working with facilities and transplant centers to make great progress in this area. I do want to recognize DeVita Nansemond for adding 16 patients to the wait list and having 9 transplants. FMC Prince William County had 13 patients added to the wait list in this time period and 12 transplants. And then IDF Calvert Center added 3 patients to the wait list and had 4 transplants. That's great work. Really appreciate your efforts here. Like home, transplant will remain a focus for this performance period. We're looking to achieve a 20% increase in the number of patients added to the wait list, and then a 30% increase in patients actually receiving a transplant. Vaccinations, we had 2 goals in this area, keeping patients up to date with their pneumococcal vaccines. We exceeded that goal with more than 55% of patients being up to date. And then for influenza, it was 79.5 with a goal of 80. So we feel very confident that we would have met that goal as well. And if you round up, then we did meet it. So excellent work there. Amanda has really done amazing work with working with the facilities on helping to establish processes and procedures for vaccinations, but also with data cleanup and assisting with getting data into EQRS. So appreciate the efforts there. I do want to recognize the following facilities who had over 95% of their patients vaccinated for influenza and had the most significant improvement in their pneumococcal vaccines. So those facilities include DeVita Gaithersburg Dialysis, DeVita Forest Landing Dialysis, BMA Columbia Heights, and DeVita Ashburn Dialysis. Thank you so much for your work here. Really appreciate the improvements on that pneumococcal and exceeding the influenza goal as well. Vaccines will remain a focus. The same two measures, looking for 80% of dialysis patients receiving the influenza vaccine, and then a 13% increase in the rate of patients who are up to date for their pneumococcal vaccine. So really, we're continuing to work on the same things. The bar has just gotten higher. Okay, looking at hospitalizations, we had two measures in this area as well. Inpatient admissions. Remember, for hospitalizations, this is an upper threshold, the gold bar is, and we actually want to remain below it. So for admissions, we were above the threshold, and with ED visits, we were able to remain below that upper threshold. These facilities showed great improvements in reducing hospitalizations and ED visits. So Deerhead Center, BMA Camp Springs, DaVita Cantonsville Dialysis, DaVita Charter Colony Dialysis. Appreciate your work here. Please keep it up. You know, the goal of quality improvement is really putting policies and procedures in place and following those, and that way we'll continue to improve. So hopefully we can keep the momentum going in all of these areas. Because hospitalizations is also staying around for the next performance period, looking to decrease hospital admissions and emergency department visits by 15%. Patient and family engagement, we have three measures in this area that we focused on, including patients in QAPI, helping them develop life plans, and then offering peer mentoring programs within your dialysis facilities. And you can see that we exceeded the goals in all of these areas. Renee has been dedicated to this work for many, many years, and appreciate everything that she has done. As you heard me say earlier, these measures will not be included in our contract this performance period. However, you will still see Network 5 using patient and family engagement interventions in all of the work that we do. I do want to recognize these facilities who are all newly added to the option year 3, that's our previous performance period, to the group of facilities who have achieved full demonstration of patient and family engagement in all 3 areas. So IDF Chestnut Square, Renalis Capital Region, UVA Zion Crossroads, UVA Augusta, UVA Farmville, and UVA Stanton. This truly is great work, and appreciate your dedication to patient and family engagement, and I hope you will sustain it. Moving on to data quality, we look at 2 things here, and this is all getting your 2728 and 2746 forms submitted into EQRS on time. We exceeded goals in both of these areas. Allison has done great work with the facilities of sending reminders and providing some best practices of how to put policies or procedures in place to get these forms submitted on time. I'd like to recognize UVA Stanton, US Renal Care Petersburg, Puddle Duct Dialysis, Samadas Dialysis, Mount Vernon, and Wheeling Dialysis for outstanding work in data quality. We'll continue to look at these things over this performance period, hoping to see an increase of 15% on getting those 2728 forms submitted in EQRS within 45 days of admission, and then a 20% increase in the 2746s submitted on time, and that's within 14 days of the patient's death. Okay. I want to take a pause for a second because I realize there are several goals to pursue here. Most of these goals align with other program measures, which is good news. They align with the ESRD QIP. And, you know, typically if you perform well on network goals, it's going to help your performance on the ESRD QIP and the 5-star ratings. We want to let you know that the network is here to help you, but we need to be available when you need us. So I want to pause for a second and offer a polling question to see what kind of improvements we need on our availability. So our question is, are network staff available when needed? Yes, always, yes, most of the time, or no. I'm also going to offer, we're open to feedback and suggestions here. So if you have some ideas of how we can improve, or just additional things that we could offer, please put that in the chat and we will see what we can do. I'll give you another second or two. I see the responses are somewhat slowing down. Okay, it's slowing down. So I'm going to end the poll and I'll share the results with you all. Good news is that 56%, the majority of you say yes, we're always available when needed. 35 say most of the time, and then 8%, this is much higher than what I would like to see, but would see that we have some work to do, but 8% say no, we're not available when needed. So either way, if you have some suggestions for us, please put those in the chat or send me an email, give me a call. We are always open for feedback and suggestions. So thank you so much for providing that feedback. Okay. Am I still sharing my screen? Yes. Okay. At this time, I'm going to turn things over to Andrea, and she is going to talk about the non-clinical factors impacting patients' health.
Hello. You all may have already heard of the health equity measures. I think this time last year, we shared with you all new QUIP measures, the quality incentive program measures that rolled out. There were 3 health equity measures. The first one, the majority of you have already completed, and that was all around just documenting your commitment to health equity. The measures that are open right now and will remain open until February of 2026 is the screening for social drivers of health, which are the non-clinical factors that impact a patient's health. Right now, what CMS is asking for you all to do is to screen for food insecurity, housing instability, transportation needs, utility difficulties, and interpersonal safety. For some of you, particularly those of you who work at a large dialysis organization, your organization likely already has an internal system where you all are able to screen and document for these 5 domains that I just named. And at some point between now and the end of the performance period in February, your internal system will batch your responses for screening and send them to EQRS, formerly known as Crown Web. That is how you meet this measure. The purpose of you all screening is really to just better identify, document, and meet the needs of patients and the communities in which they live. We all know that you all already screen for the majority of these measures. The only difference with this QUIP requirement is that CMS is asking that you document your responses to this screening in EQRS. For those of you who have to document manually, you just need to do so by 2026 February. Next slide. Thank you. To meet this QUIP measure, you really only need to screen your patients annually, but I will say that the best practice is to screen the patients anytime there is any change in status. So if you know that a patient has recently moved, or if they've lost a loved one, received a new diagnosis, if they have changed modalities, or even if they or someone who has a frequent hospitalization, that is a change of status, and that might trigger the need for you all to screen the patient to see if there are any changes in any of those domains that I mentioned, just the food insecurity, transportation needs, and the 3 others. So really just kind of the major domains of non-clinical factors. The way that you want to help patients understand the importance of the screening is just to provide some context, really help patients to understand the link between us screening. This is not a screening just for the purpose of having yet another screening, but it's really to identify where there are some gaps that are impacting their care. And I will tell you that the more that we are able to document this information, it puts us as providers in a really great position to share with CMS where the needs are, and hopefully that will be able to help us get more funding around some of these needs. We also want to be mindful of when and where the conversations are taking place. I know that I've had some patients reach out and ask me some questions about the screening, and these are just patients who we have as a part of our pack. You might find that some of your patients want to have the screening done over the phone, where some might want to do it in a back office, and some will be perfectly fine with having it at chair side, but kind of being mindful of when and where the conversation takes place does help to provide some more accurate responses. Again, just want to remind you to rescreen after certain incidents of trauma or change. And as you are screening, of course, you're going to learn about where there are barriers for some patients. And so when you find those barriers, you can utilize the community assets profile, which I will share in the chat the link to. We have a library to the community assets profile, our CAP. This profile is really just an aggregate of resources. It is on the county level. If you work in Maryland, then there's already a CAP. All of the counties in Maryland have a CAP. Virginia, we are continuing to work on those. All of DC, so all of the wards in DC already have a CAP that is available and ready to access. So as you're screening patients, you're identifying that there are barriers in any of the domains that you screen. The CAPS is already documented in such a way that we have listed the domains, and then we have resources for each domain. If you have any questions about this, then let me know. There are exclusions, patients exclusions and facility exclusions that are listed, and I will share in the chat as well what those exclusions are. But there are exclusions saying which facilities are excluded from having to meet this QUIP requirement and which patients are excluded from having been screened. So I will share that, and if you have any questions, you can either say so in the chat, or I'm sure we'll have a Q&A at the end of this. Thank you, Brandy.
Thank you, Andrea. Real quick, you mentioned Maryland, Virginia, and DC. What's the status of
West Virginia. Yeah, West Virginia, working on those as well. I know some of you have reached out to me to ask me about a CAP in a particular county. Please know that as this is a continuing and an ongoing initiative. So West Virginia does have CAPs available. It can be found at the link that Heather shared. As I am working on these CAPs, I'm really focusing on those counties that have been identified as the least healthy, and we use data. We use county, city data to identify which counties have been listed as the least healthy. So trying to provide resources to those counties and then working our way to the most healthy counties last.
Perfect. Thank you so much. Okay, I'm going to turn things over to Renee next to talk about grievance trends.
Great. Thank you, Brandy. So an important part about our contract is looking and helping patients with the grievances that they have. We're also a resource for facilities with any behavior concerns you have in your facility with patients. Or resources, whatever, call. We are a resource. And it's also particularly in situations where you're having concerns with patient behaviors. We are a good third-party person that's removed from the situation to kind of bounce ideas off of and make sure that you guys are thinking about everything from as many different perspectives as you can and considering all the alternatives and options. So please use us as a resource for your concerns and needs. So in looking at this graph, I want to point out that grievances, the number of grievances that we have been getting through the years has been declining, which could be good or bad. I haven't quite figured that out yet, but we will err. We could err on the side of caution, but let's just say that facilities are doing a good job handling grievances internally. It's important, and I'll get to this, but it's important that you make sure that patients know about their grievance options, so that they know the network is a resource for them if they have a concern. So in looking at this graph, let me tell you what each of these categories represents. So clinical quality of care concerns are those that typically relate to things associated with the care that's being provided. So like physician orders or safety issues. And then treatment is typically about concerns related to things like chair scheduling and the hours of operations, how early or late a facility is open or closed. And then the shift that a patient is assigned, or maybe where their seat is located. Staffing issues typically relate professionalism, the perception of competency, and then environment is typically about concerns related to bugs, televisions not working, chairs not working right, general repair of equipment, cleanliness of the facility, and then others, just anything that doesn't fall into any of those buckets. So the treatment related, so that's in the gold bars, the treatment related concerns have historically been the highest, but they have been declining through the years. And in fact, in last year, 2024, there was a flip, and the staffing concerns overwhelmed everything. Patients were just calling about concerns about staff-related issues. So these are just, I think, important things to note. I'm going to talk a little bit more about this type of analysis in one of the next slides. But for now, I think that it's important to note that that patient concerns are things that we need to really try to emphasize to patients, that we are listening to them, that we want to get to the bottom of their concerns, and that we want to address those, and to circle back with patients to make sure that they know that we haven't forgotten about them and what the outcome was. So when a patient expresses concerns in the dialysis facility, that those things are very important to ease their minds, because if they don't feel like they're being heard or that their concerns are being addressed, that can lead to discontent, which can increase or escalate to, animosity and worse, outbursts, threats, whatever, which of course can lead to involuntary discharge, which we don't want to have happen. So it's, I think the easiest way to manage patient behaviors is to listen to their concerns and try to address them as best we can, and ensure that they understand that we are trying to make them comfortable. All right, we can go on to the next slide. Or maybe we have a...
Yes, we have a quick check-in. I'm trying to launch it and seem to, oh, there we go. Okay, here we go. Is there a green and blue grievance poster hanging in your facility that is easily accessible to patients? An easy yes or no. right. Responses have slowed down, so I'm going to go ahead and end the poll and share the results. We are happy to report that the majority, 85% of you say yes, there is a poster, a grievance poster hanging in your facility that is easily accessible to patients. For those of you, the 9 of you that say no, please contact us. We can mail you one, or there is a copy on our website that you can download and print either at the printer in poster size or print in your office as just an 8.5 by 11. That works too. Okay, Renee.
Yeah, and make sure, yeah, you can advance. Make sure when you, if you do have the blue and green poster, check it to make sure that it has the PO box listed as our address and not a street address. We no longer have a street address. It should be the PO box. And if it has the street address and your poster's in pretty good shape, then, you know, you can just update it with our PO box address with like a label, and just type it on that and then stick it on the poster. But make sure that it's clearly posted where patients can easily see it. I hear from patients a lot that they don't know where this information is. We all know that paper becomes wallpaper after a while on bulletin boards and things. So it might be a good idea, you know, on maybe an annual basis to print this thing off and hand it to patients, or to print your policy on grievances, how to get those addressed, to hand all that information out to your patients once a year, just as a general review, so that they know what their options are. The state surveyors are looking for those posters, so be aware of that. Also, I think it's important for facilities to do regular in-servicing on professionalism, boundaries, and de-escalation, particularly after an event has concerned. I think a debrief with the staff is very important and very beneficial to try to figure out what happened. How did we all respond to it? Was there anything we could have done differently that would have prevented the situation from occurring in the first place, or could have made the outcome better? You know, really trying to understand what happened and what steps were taken and could have been different. I think these things are very important. I also think an annual in-servicing really is inadequate. We see these patients quite frequently. We're doing our job quite a lot, you know, in a routine manner. And so it is easy for us to forget things and to, you know, to forget ourselves. So to keep it in front of everyone as a reminder, I think at least quarterly would be a best practice. Certainly after an event, that would be a great time too. So, so consider those things. In addition, tracking and trending your grievances. This is something that you all are probably doing in your QAPI as far as reviewing grievances that you've had from the previous month. What my impression is that's basically a report out. I think it is important that you all do something like I just showed you on the graph, where you're looking at a few years, at least one whole year's worth of data. What are your trends? What are these grievances about? Are they repeating over and over again? Do they relate to the same staff over and over again? These are important things to kind of get to the root of what is driving patient discontent and what could be done to try to address that. So consider those things. And if you need help with any of that, I'm happy to help you. We can go to the next slide, and we'll talk about involuntary discharge. And this graph, again, shows that over time, the number of involuntary discharges has been going down. And I think that is fabulous. That is exactly what we want to have happen. We don't want people being discharged. involuntarily. So it's great that this number is going down. Kudos to everybody for the hard work on that. Additionally, the gold bars are representing the discharges for immediate severe threat. It's an immediate discharge for severe threat. Those numbers are also in decline over time, which again is great. The line bar, the line, I don't know what that is, the line represents the percentage of those total involuntary discharges that were due to immediate severe threat. So that percentage is going up, which means that gap is getting tighter. So more and more, the reason for involuntary discharge is because of these extreme behaviors. While that is not delightful, we don't ever want severe behaviors, it is representing that it is a last-ditch effort to work with patients to keep them in the facility, and it's these egregious behaviors that are causing the discharges. So that is ideal. That is where the line is drawn, okay? So good work, everybody, on that, and keep that up. And again, use us as a resource because we certainly want this trend to continue downward. We would like to avoid any discharges in the future, particularly any situations that escalate to the point where there is danger. So let's go to the next slide. And this is talking about failure to place patients. These are patients, and I excluded patients that were involuntarily discharged because oftentimes they are difficult to place for obvious reasons. So this is only looking at other reasons for involuntary discharge, which includes behavior that did not lead to involuntary discharge, mental health, non-adherence, medical need, and payment. So the payment meaning that there is no payment coming in. What I think is interesting to note here is that the really vivid blue that's in there representing non-adherence is primarily the reason why patients are not getting placed into dialysis facilities. And many of these also are, these patients had a facility, but they went out, they were gone for over 30 days. And so the facility, discharged them internally, but now are refusing to reaccept them. I will challenge that every time. So that until a patient is formally handed off to another facility for care, that patient belongs to you. If you have any questions about that, please give me a call, but patients should never be denied readmission because of non-adherence. Or you're going to hear from me or the state, one or the other. I think the other thing I wanted to point out is that just an interesting tidbit that I've noticed over the years is that it is easier to place a patient who has exhibited violent tendencies than it is a patient for non-adherence. That is very distressing to me. So be aware of that, and let's work together to make sure patients are getting the care, the access to the care that they deserve. So I think, oh yes. So I think I also, you can leave it here, Brandy. I think it's also important to talk about when that, oh gosh, I lost my train of thought. So I know, life planning, that this is a great, any of this, whether patients have grievances or you've got concerns about their care based on their behavior, that these are great opportunities to have conversations about what they want from dialysis. Life planning is a great way to get with patients about what is driving their behavior and what do they want from their treatment, and how can we help kind of have a meeting of the minds on this and identify what their goals are for dialysis and how, or their goals for life. What do they want out of their life, and how can we fit dialysis into that? These are important conversations that we can have that can help drive patient behavior in a more positive way. And so that Andrea doesn't have to chime in. Also, social determinants of health, that screening should take place again. Oh yeah, I guess I jumped ahead of myself, didn't I? So did you want to do that poll, Brandy? I'm rambling, but I can come back.
It's okay. You were covering this stuff, so I thought I'd just put the slide up to support it.
I just got ahead of myself.
It's okay.
Okay, so I'll just finish with this. I'll finish with this, and we'll go back to the poll.
Perfect.
So definitely have, again, regular staff in servicing on professionalism, boundaries, and de-escalation. This is all part about keeping patients in a comfortable space so that they don't feel like they have to fight for anything. But we want to ensure that we are understanding patient needs and their triggers so that we can keep them safe for dialysis in the center and keep calm in the unit. I mean, I think that's everybody's goal. Make sure that if you are having concerns about behaviors, that you mark them as unstable for care planning so that they are touched on monthly. It's also probably a good practice, with your daily huddles, review the patients that are there for the day. Who do you have concerns about? And what do people need to be mindful of? Are there some staff that work better with patients who could provide some guidance on how they manage the patient if you're not that person and you are assigned the patient? Just different ways to try to kind of meet the patient where they're at and help keeping calm. All right, I think I did cover all the rest of this, so we could go back to the poll.
Okay, so we have another check-in. Let's see if I can launch it correctly. Okay, how often does your facility conduct in-servicing on professionalism or de-escalation? Your choices are anytime there is an incident, at least quarterly, annually, or you don't remember the last time. Okay, it slowed down, so I'll end the poll and share the results. It looks like the majority of facilities are doing it annually, which we have heard Renee say that that is not enough, that at least quarterly would be the preference, or anytime there is an incident, which that was tied at 24, and then 16% don't remember the last time. So maybe go back to your facilities and talk about getting some training scheduled if you don't remember. All right, any other comments on this, Renee?
Nope, I'm good, thank you.
Thank you for the feedback, everyone. We are just about ready to wrap things up. And we'll do that with network expectations. I find these fairly easy and reasonable. We ask that you engage with us, that you respond to the inquiries and requests for information, giving you a heads up that the personnel updates are being released on the 26th, so that is tomorrow. This is really important for us so that we know who are the staff members in your clinic so that we're contacting the right people. We ask that you take action when you get requests from us and that you sign up and read our electronic newsletter alerts that goes out about every other Friday. Notify the network of major events like facility emergencies and closures, and then of course of leadership and staff changes. This is in addition to that quarterly personnel update. If something happens in between, please let us know. We ask that you inform patients of available network resources, of course, hanging the grievance poster and the process for filing a grievance. Our website is full of educational materials for patients family members and staff members, and then make them aware of opportunities with our Patient and Family Advisory Committee. Finally, for you all to pursue network goals and participate in our quality improvement activities. Notifications have been going out in the past couple of weeks about all of our QIAs that are happening this performance period. So please remain engaged with the network staff about those, as well as technical assistance. And then when you are notified that your ESRD facility report has been updated, that you are accessing that every month, and you're discussing and documenting in your QAPI meetings how you are working towards network goals. So I do want to share that, of course, your ESRD facility report has not been updated since April because the network doesn't have any data. That does not mean you should not be discussing network goals. I just went over all the network goals with you. You still need to be pursuing those and making plans of how you're going to reach those goals, because the state surveyors are still going to be looking for that documentation in your QAPI meeting minutes. Finally, some key takeaways. All facilities are required to be working on all goals. Even if you're not in a specific project, you are to be working on all of the goals anyway. And then, of course, engage with us as required by the conditions for coverage. An updated staff and contact list. You have all of our email addresses. You call this main line, and then our extensions are over here in the final column. So please reach out if you need anything. We are here to assist. That is going to do it for us. So we are happy to take any questions. I saw some chatter over in the chat. Feel free to put questions, additional questions in the chat, or come off mute and engage with us directly.
Yeah,
all right.
Angela's got a question that I'll take regarding patient engagement. And it sounds like the state was in the clinic, and the clinic shared with them that they were playing bingo, having contests, including patients in care plan meetings and the QAI, and the state said that was not enough. I don't know what the state is looking for. That is our expectation, is that you guys are including patients any way you can in your, in your review of quality measures, as a partner in their care plans, trying to engage them in their own care, and life planning is a part of that. Trying to help connect them with each other, using peer mentors for that, or just helping patients to find some friends, which is a strategy for increasing attendance. As well as just utilizing patients to help with education with each other. So, I mean, those are primary ways of engaging patients in care. So, if you all find that you're in a situation like that, feel free to give us a call right in the middle of your survey, and we'll be happy to try to figure out with you and the state what it is that they're looking for. Okay.
And thank you, Angela, for sharing that example and asking the question. Other questions? Heather, Andrea, thank you for putting these resources in the chat. That is great. Okay, not hearing anything else, that is going to conclude our presentation for today. Yes, I can put the contacts back up. This is also available on our website. So yeah, the website is up there at the top. Really cannot stress enough how often we hear that dialysis facility staff aren't aware of our website. It is full of information, so please check it out, including our contact information, direct links to our to email us. So please check that out when you can.
Yeah, and if you call, I mean, you can see we're a small staff. I mean, we will get you where you need to go. So if you call and you don't know who to talk to, you can either leave it in the general voicemail or just, take your best guess. If we can't answer your question, we'll get you to the person who can.
Yes. Okay, that is going to do it for today's presentation. Again, the recording and slides will be available on our website probably next week. So feel free to review if needed or share with colleagues who weren't able to join us. You all have a great day and try to stay cool out there. Bye-bye.
Thank you. Bye-bye.